Let's get started with chapter number 28, which is cardiovascular system infections. In this unit, we will be covering infective endocarditis, other infections of CVS, and acute rheumatic fever. So, to start with, the author says that the cardiovascular system infections include infections of heart and blood vessels. Infections of heart includes of all the three layers of the heart wall, which is endocardium, myocardium, and pericardium. The endocardium infections the endocardium is the innermost layer of the cardiac wall, and its infection is known as infective endocarditis. The myometrium is the middle layer, which is composed of cardiac muscle, which is an involuntary striated muscle. It is responsible for contraction of the heart. Infection of the myometrium is known as myocarditis. Pericardium is the outermost layer of the heart, composed of connective tissue and fat. The connective tissue secretes a small amount of lubricating fluid into the pericardial cavity, and the infection of pericardium is known as pericarditis. Collection of excess fluid in pericardial cavity can lead to pericardial effusion. Other than this, infection of blood vessel can occur, which can be mycotic aneurysm, infective endarteritis, device-related infections like CRIPC. CRIPC is catheter-related bloodstream infections, and suppurative thrombophlebitis. Or other than this, it can be autoimmune-related acute rheumatic fever. So let's start with infective endocarditis. The infective endocarditis states that microbial invasion of the heart valves or mural endocardium leads to infective endocarditis. It characteristically results in formation of bulky, friable vegetation. Friable means something which can dissociate easily, which is composed of a mass of platelets, fibrin, microcolonies of organisms, and scanty inflammatory cells. Vegetations are most commonly present on the heart valves, followed by the low pressure side of a ventricular septal defect and on the mural endocardium. The classification of infective endocarditis can be classified into acute and subacute forms based on the rapidity of evolution of infection and virulence of the implicit organism. So, we can see that acute endocarditis is a rapidly damaging infection of the cardiac structures and spreads to extracardiac sites also, frequently involving a highly virulent organism like Staph aureus, attacking a previously normal valve and capable of causing substantial morbidity and mortality even with appropriate antibiotic therapy and or surgery. The subacute endocarditis, it usually occurs in a previously damaged heart, example scarred or deformed walls, and the implicating organisms are of low virulence, example virulent streptococci. The disease typically has insidious onset and metastasizes slowly, and it's gradually progressive over weeks to months. Most patients recover after appropriate antibiotic therapy. The pathogenesis of infective endocarditis. The pathogenesis of infective endocarditis involves the following steps. We'll see the risk factors. Before that, let us see the table 28.1, which is the difference between acute and subacute endocarditis. In acute endocarditis, the evolution is rapid, while in subacute, it's slow. The acute one involves normal cardiac valves, while subacute one involves previously damaged, scarred, or deformed valve. The acute endocarditis is implicated in organism of high virulence like Staph aureus, while subacute one is related to virulent streptococci. Causes of acute endocarditis, it causes substantial morbidity and mortality even with the appropriate antibiotic therapy or surgery, while the subacute endocarditis is usually progressive to course of weeks or months, but most of the patients recover after antibiotic therapy. Less common is the acute endocarditis, which occurs in 10 to 20% of the cases, but more common is subacute endocarditis, which occurs in 50 to 60% of the cases. So coming back to pathogenesis, first are the underlying risk factors like infective endocarditis is usually predisposed by the various risk factors like underlying cardiac defect. The cardiac conditions are most commonly associated with infective endocarditis are congenital valvular diseases such as mitral valve regurgitation, aortic stenosis, or aortic regurgitation, or ventricular septal defect, or it can be due to use of an intravenous catheter or a prosthetic valve replacement surgery. Okay. Other than this, the endothelial injury will occur. So the endothelium, unless damaged, is resistant to infection by most bacteria and to thrombus formation. Therefore, though infective endocarditis can develop on previously normal valves, but it is more common to develop on a defective valve. This is because predisposing cardiac abnormalities produces turbulence in the blood flow to heart, which can result in damaged cardiac endothelium. The use of IV catheter induces direct trauma that can damage cardiac endothelium. This damage to endothelial surface results in the deposition of platelets and fibrin, a condition called non-bacterial thrombotic endocarditis (NBTE). Okay. Now will occur the colonization. In colonization, the thrombus subsequently serves as a site of bacterial attachment during the transient bacteremia. When bacteria transiently gain access to the bloodstream, example brushing the teeth, the organism may stick to and then colonize the damaged cardiac endothelial surface. Now will occur the formation of vegetations. Now the endothelial surface will get rapidly covered with a protective layer of fibrin and platelets. This protective environment is favorable to further bacterial multiplication. This web of platelets, fibrin, inflammatory cells, and entrapped organism is called a vegetation. Okay. Now occurs metastasis. Resulting vegetation ultimately seed bacteria into the blood at a slow but constant rate, which can metastasize to distant sites. So this vegetation can be seen in this figure 28.1, in which subacute bacterial endocarditis involved mitral valve is showing a large vegetation on the valve leaflets. Alright. Now coming to the etiological agents of infective endocarditis, the causative organism of infective endocarditis differ depending on the underlying risk factors such as native or prosthetic valve, acute or subacute infective endocarditis, other risk factors such as IV drug abuser, etc. Okay. So the organisms differ from each other in the primary portal through which they enter the bloodstream. Alright. Okay. So and they reach the heart. For example, through the oral cavity, what can reach? Viridin streptococci. Staphylococci can reach by skin. Upper respiratory tract for Hassec organisms, and the gastrointestinal tract will be the pathway for Streptococcus, Galoticus, and Enterococci. Okay. So, coming to the clinical manifestations, the clinical spectrum of infective endocarditis includes both cardiac and non-cardiac manifestations. Because the cardiac manifestation will include the appearance of a new or worsened regurgitant murmur, which is more useful for diagnosis of infective endocarditis involving a normal valve, while the non-cardiac manifestation will include fever, chills and sweats, anorexia, weight loss, myalgia, arthralgia, arterial emboli, splenomegaly, clubbing, fatigue, neurological manifestation and peripheral manifestations like Osler's nodes. Osler's nodes are results of immunologic phenomena, while the and Janbei lesions, which are the result of vascular phenomena. The lab manifestations such as anemia, leukocytosis, microscopic hematuria, elevated ESR, CRP, or rheumatoid factor can also be seen. The diagnosis of the disease is made by the modified Duke's criteria. In the diagnosis of infective endocarditis, modified Duke's criteria involves blood cultures, in which isolation of these causative microorganisms from blood cultures is critical for diagnosis, determination of microbial susceptibility, and planning of the treatment. Blood culture should be collected before antibiotic therapy. It can be in two forms, like 2 blood culture sets should be collected at an interval of more than 12 hours between first and second set, or 3 blood culture sets can be collected over 1 hour, example 30-minute gap between first and second set and 30-minute gap between second and third set. Now, the blood culture set refers to the pair of bottles, like in each finding, the sample is collected from 2 different sites so that there are no chances of any discrepancy. Now, for the diagnosis, the major criteria or the minor criteria, as will we see further, should be fulfilled. Like, major criteria can be fulfilled if a typical infective endocarditis organism is isolated from 2 separate blood cultures, or agent other than typical infective endocarditis is isolated persistently from blood cultures in the absence of extracardiac focus of infection. Or now, a minor criteria can be considered to be fulfilled if the blood culture show positive but not meeting a major criteria. Blood culture collection technique and processing will be discussed further. Okay. So coming to the table 28.2, agents of infective endocarditis, like etiological agents and of infective endocarditis which are important to learn are Staphylococcus aureus, coagulase negative staphylococci like Staphylococcus epidermidis, streptococci, viridin streptococci and others, enterococci, pneumococci, fastidious gram-negative coccobacilli Hessek group, enterobacteriaceae, Pseudomonas species usually in drug users, Candida species, diphtheroids. The most common agents in specific type of endocarditis are in native valve endocarditis, most common is Staph aureus. In community acquired endocarditis, it's viridin streptococci. In healthcare associated, it's Staph aureus, and overall, it's Staph aureus only. Okay. In a prosthetic valve endocarditis, early prosthetic valve endocarditis, which occurs within 12 months of valve replacement, is generally nosocomial, results from intraoperative contamination of the prosthetic or bacteremic postoperative complication, and coagulase negative staphylococci like Streptococcus Staph epidermidis and Staph aureus are the most common agents. The late prosthetic valve endocarditis occur after 12 months of valve replacement, and usually community acquired viridin streptococci are the most common agents. Overall, regardless of the time of onset after the surgery, coagulose negative staphylococci are the most common agents of majority of methicillin, and majority are methicillin resistant coagulase negative staphylococci. Endocarditis in IV drug abusers, young males, are at the most common risk. The skin is the common source of infection. The right-sided tricuspid valve endocarditis will be caused by Staph aureus. A majority are MRSA, methicillin-resistant Staph aureus. Okay, while the left-sided mitral valve endocarditis will be caused by more variety of organisms like Enterococcus followed by Staph aureus. However, Pseudomonas aeruginosa, Candida species, and sporadically by unusual microorganisms like Bacillus, Lactobacillus, and Corynebacterium species can also be implicated. Overall, most common agent of endocarditis in IV drug abusers can be occurred as Staphylococcus aureus. Subacute endocarditis can be caused by viridin streptococci, and culture negative endocarditis from the 10% of the infective and negative blood cultures, majority one third or one half of which is because of prior antibiotic exposure. The remainder of these patients are infected by fastidious organisms such as nutritionally variant streptococci, है ना, like granulicella है और abiotrophia. Okay, the Hasse group of organisms, the Coxiella burnetii, Bartonella species, Brucella species, Tropherma vipelli, which causes an indolent culture negative afebrile form of endocarditis. Okay, and other than this, some fastidious organisms occur in characteristic geographic settings. Example: Coxiella burnetii and Bartonella species in Europe, Brucella and species in the Middle East. All right. So these Hassek organisms, we should know that Hassek organism is the abbreviation for a group of organisms like Haemophilus species, Aggregatibacter species, Cardiobacterium hominis, Echella corrodens, and Kingella kingi. Okay, and con stand for coagulase negative staphylococci. So these were the blood cultures. Now coming on to the non-blood culture test. Various non-blood culture tests can be used for the diagnosis of infective endocarditis, which includes serologic tests that can be used to implicate some organisms that are difficult to recover by blood culture, like Brucella, Bartonella, Legionella, Chlamydophila pistachii, and Coxiella burnetii. Isolation of the pathogens in vegetations by culture, microscopic examination with special stains, example periodic acid Schiff stain for Trophonema vipelli, direct fluorescence antibiotic techniques, PCR to recover any unique microbial DNA or 16S rRNA that when sequenced allows identification of the etiologic agent. Okay. Other than this, echocardiography also allows the anatomic confirmation of infective endocarditis, sizing of the vegetation, detection of the intracardiac complications, and assessment of the cardiac function. For the treatment, what all we can do is treatment regime for Staph aureus for MSSM, which is methicillin susceptible Staph aureus, coaxiacillin or nafcillin is given for 6 weeks. For MRSA, methicillin resistant Staph aureus, vancomycin is given for 6 weeks. For prosthetic valve endocarditis, in addition to above regimen, rifampin for 6 weeks and gentamicin for 2 weeks are added. While regime for viridin, streptococci, and staphylococcus includes for native valve infective endocarditis, penicillin or ceftriaxone is given for 4 weeks. For prosthetic valve endocarditis, gentamicin is added to the above regimen for 6 weeks. For Hasek endocarditis, ceftriaxone or ciprofloxacin is given for 4 weeks. Treatment may be extended to 6 weeks in case of prosthetic valve endocarditis. Therapeutic drug monitoring. Optimum dosage is key behind a successful clinical outcome. Therapeutic drug monitoring should be performed to maintain optimal antibiotic level in the serum. Like vancomycin dosage is 15 to 20 mg per kg, Q 8 to 12 hours. Target through concentration of 15 to 20 microgram per ml needed to be maintained. Vancomycin should be avoided if MIC is greater than 1 microgram per ml. Gentamicin dosage is 1 mg per kg, Q8H IV. It is used for synergy. Peak levels need not exceed 4 microgram per ml and troughs should be less than 1 microgram per ml. Okay. So now coming on to agents which cause endocarditis. Infective endocarditis due to staphylococci. Okay, so we'll classify it as staphylococcal endocarditis, right? So, Staph aureus is the most common cause of infective endocarditis, which usually runs an acute course. Like Staph aureus, i.e., presents with larger vegetations more than 10 mm in diameter and therefore is more frequently associated with features of septic embolization. Okay, due to breaking of vegetation leading to formation of emboli, such as subungual hemorrhage, Osler's node, etc. So, other than this, cerebrovascular emboli can cause strokes or occasionally encephalopathy, and embolization risk is higher for mitral valve infective endocarditis. Staph aureus appears gram-positive cocci arranged in cluster, produces golden yellow hemolytic colonies on blood agar, and gives a positive coagulase test. Coagulase negative staphylococci like Staph epidermidis are increasingly associated with prosthetic valve endocarditis. Okay. Here. And majority of them are methicillin resistant. Staphylococci can cause infections of various other systems of skin, like skin and soft tissue. Coming to viridin streptococci are commensals of mouth and upper respiratory tract. Usually they are non-pathogenic, however, occasionally can cause diseases such as subacute bacterial endocarditis, SABE. Viridin streptococci are the most common cause of SABE. The commensal viridin Streptococcus sanguinis is in the oral cavity, can enter the blood to cause transient bacteremia while chewing, toothbrushing, dental procedures that can account for the predilection of these organisms to cause endocarditis. The dental caries is mainly caused by staph mutans, which breaks down dietary sucrose to acid and dextrins. With the help of enzyme glucosyl transferase, acid damages the dentine, while adhesive dextrin binds together with the food debris, mucous, epithelial cells, and bacteria to produce dental plaques. In cancer patients, viridin streptococci can cause prolonged bacteremia among neutropenic patients undergoing cancer chemotherapy. And Streptococcus miliari group includes Streptococcus intermedius, Streptococcus angiosus, and Streptococcus constellatus. They produce suppurative infections, particularly brain abscess and empyema. In the lab diagnosis of viridin streptococci, we can do gram staining. On gram stain, they appear gram-positive cocci arranged in long chains, such as shown in figure 28.2a. You can see long chains. Okay. And other than this, they can appear alpha hemolytic green colored colonies, non-hemolytic colonies also on blood agar. Viridis means green. Okay, in figure 28.2b we can see this 28.2b. Okay, alpha hemolytic colonies on blood sugar can be seen. Okay. So they can be differentiated from Streptococcus pneumoniae, which is also alpha hemolytic, by a number of tests such as resistant to optocin and insoluble in bile. And accurate species identification is made by automated methods like Malitov. For treatment, most strains are susceptible to penicillin, and resistant isolates may be treated with penicillin plus gentamicin for lower level resistance, or ceftriaxone vancomycin for high resistance. Okay. Now, coming on to nutritionally variant streptococci. Abutrophia and granulicatella species are known as nutritionally variant streptococci as they require vitamin B pyridoxal in the culture medium for their growth. Earlier, they were grouped along with the virulent streptococci only. So the manifestation of this is that they are normal inhabitants of the oral cavity and similar to other common cells. They can also cause endocarditis. In the diagnosis, they can be recovered in automated blood cultures like BAC or alert. Multiple blood cultures and prolonged incubation may be necessary. But they fail to grow when subcultured on solid media. However, they sometimes produce satellite colonies near the colonies of helper bacteria. Okay. Example near the Staphylococcus tricline. Therefore, they are also called satelliting streptococci. They are catalase negative, gram positive cocci arranged in short chains. Species identification is made by automated systems like Malditov, and the treatment involves combination therapy with penicillin plus gentamicin. Okay. And now Galoticus endocarditis, formerly known as S. bovis, is a group of D. streptococcus found as common cell in intestine of animals, and in humans it occasionally causes bacteremia, subacute endocarditis, and also associated with colorectal cancer or polyps. Penicillin is the drug of choice. HASEC endocarditis. HASEC is an abbreviation used to represent a group of highly fastidious, non-growing capnophilic gram-negative bacteria that normally reside in the oral cavity as commensal, but occasionally have been associated with local infections of the mouth and systemic infections such as bacterial endocarditis. Species belonging to this group include Haemophilus parainfluenzae, Aggregatibacter species like Aggregatibacter acetocomitans, and Aprophilus and Paraprophilus. Okay, Cardiobacterium hominis, Echinella cordens, and Kingella kingi. HASEC endocarditis accounts for 3% of the total endocarditis cases. Alright. So coming on, it typically has a subacute course, occurs in patients with pre-existing valvular defects or those undergoing dental procedures. The aortic and mitral valves are most commonly affected. Clinical manifestations. Haemophilus parainfluenzae is a common cell in mouth and throat. Occasionally, it can be opportunistic pathogen causing endocarditis, conjunctivitis, abscess, genital tract infections, and bronchopulmonary infections in patients with cystic fibrosis. It can be differentiated from Haemophilus influenzae by its growth requirement. Okay, requires only factor 5th but not factor 10th, or by automated identification systems such as Malditov or Vitek. Aggregatibacter actinomycetin comitans, formerly called the Actinobacillus actinomycetin comitans. It is most common member of HASEC to cause endocarditis. It can also be isolated from the soft tissue infections and abscess associated with Actinomyces israeli. Rarely, it can cause periodontitis and brain abscess, meningitis, and endophthalmitis. Now, aggregator Aprophilus and aggregator Paraaprophilus, earlier members of Haemophilus, now are named under genus Aggregatibacter. They are common cells of mouth and occasionally cause endocarditis, head and neck infections, invasive bone and joint infections. And Aggregatibacter Aprophilus requires only factor 10th, whereas Paraaprophilus requires only factor 5th. Cardiobacterium hominis is a frequently affects the aortic valve. It is also associated with arterial embolization, immune complex glomerulonephritis or arthritis. Eikenella corrodens, apart from endocarditis, can also cause skin and soft tissue infections. The name corrodens refers to the characteristic pitting or corroded colonies on blood agar. Kingella kingi, in addition to endocarditis, it can also cause infections of bones, joints, and tendons. In lab diagnosis of HASEC endocarditis, it is as follows. First we do culture. Blood cultures can perform on automatic systems such as BAC-T or alert. They are highly acid fastidious, require multiple blood cultures and prolonged incubation up to 1 week. Their capnophilic growth is optimal in presence of 5 to 10% CO2. Identification is made by automated systems such as MALDI-TOF. In molecular methods, we can use simultaneous detection of HACCP members from the clinical specimen as possible by performing a broad range bacterial PCR setting targeting 16S rRNA gene followed by sequencing, multiplex PCR or multiplex real-time PCR. For the treatment, the approach is the prognosis of HACCP endocarditis is good, and ceftriaxone 2 gram per day is the drug of choice for most of the HACCP organisms except Eikenella corodense where ampicillin is indicated. Okay, quinolones are given if the strain is beta lactamase producer. Duration of the treatment is like antibiotics are given for 4 weeks for native and native valve endocarditis and 6 weeks for prosthetic valve endocarditis. So that we have covered the topic. Let's come back to the Duke's criteria of the diagnosis. In Duke's criteria we see the major and the minor criteria as told already. The major criteria involves the positive blood culture. If any of the following is present, like the typical infective endocarditis organism is isolated from 2 separate blood cultures, Virden streptococci, Streptococcus galotidis, HACCP group Staph aureus or Enterococci, or persistently positive blood culture with agents other than typical infective endocarditis organism is drawn. Blood culture sets are drawn more than 12 hours apart, or all of the 3 sets or majority of more than 4 hours separate blood cultures with first and last drawn at least 1 hour apart. Okay. Other than this, a singly positive blood culture of Coxiella brunetti or phase IgG antibody titer or more than 1:800 is a positive blood culture major criteria. Second, evidence of endocardial involvement. Any one of like a positive echocardiogram, oscillating intracardiac mass on valve or abscess or new partial dehiscence of prosthetic valve or a new valvular reagitation, all can account for major criteria. For minor criteria, the first, the predisposition, like predisposing heart conditions of IV drug use. Second, fever more than 38 degrees Celsius or 100.4 degree Fahrenheit. Vascular phenomena like major arterial emboli, septic pulmonary infarcts, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhage or Janvey lesions. Fourth is immunologic phenomena like glomerulonephritis, Osler's nodes, Roth spots or rheumatoid factor. Fifth, microbiologic evidence is the positively blood culture but not meeting major criteria as noted previously, or serologic evidence of infection with organism consistent with infective endocarditis. So this previously, it means that excluding single positive blood culture for coagulase negative staphylococci and diphtheroids, which are common culture contaminants or organisms that do not cause endocarditis frequently, such as gram-negative bacilli, abbreviation is for infective endocarditis. So definitive endocarditis will be said when if 2 major criteria or 1 major criteria and 3 minor criteria or 5 minor criteria are present. So we have completed till the last of infective endocarditis, and in the next video we will be starting with other infections of CVS and acute rheumatoid fever. Okay, so like and subscribe. Thanks for watching.